Welcome back, everyone. I hope you had a wonderful lunch. Got another cup of coffee. We're all geared up. I am very, very pleased to announce our keynote presentation. It's our pleasure to introduce you to the topic of an early intervention model for children with autism, Jasper Core Domains, Evidence and Implementation. Dr. Kasari is the Distinguished Professor of Human Development and Psychology in the School of Education, with a joint appointment in the Department of Psychiatry. She received her PhD from the University of North Carolina at Chapel Hill and has been on the faculty at UCLA, where she teaches both graduate and undergraduate courses, and has been the primary advisor to more than 70 PhD students. She is founding member of the Center for Autism Research and Treatment at UCLA. Her research aims to develop novel, evidence-tested interventions implemented in community settings. Recent projects include targeted treatments for early social communication development in at-risk infants, toddlers, and preschoolers with autism, and peer relationships for school-age children with autism. She leads several large multi-site studies, including a network on interventions for minimally verbal school-age children with autism, and a network that aims to increase equity and access to interventions for children with autism who are underrepresented in research trials. She is also the current president of the International Society of Autism Research. So now I will turn it over to you, Dr. Kasari, to present our keynote today. Thank you. Dr. Kasari, you'll need to unmute. It never fails, right? We love our technology.
Well, I've been on Zoom since 7 this morning. You'd think I would know. It's still early here.
Yes.
Okay, so let me put this back into PowerPoint mode. Can you see the screen okay? Yes, I'm hoping. Okay, good. Hello, good morning, good afternoon. As Mary said, I've been around for a while, so thank you for that, Mary. I have been at UCLA for about 35 years, and in that process have developed this early intervention model called Jasper, which I was asked to talk about. So we will be specifically focusing on this as an early intervention model, but of course there are many models out there that have proven to be effective. So what is Jasper? It stands for Joint Attention, Symbolic Play, Engagement, and Regulation, which are really the core areas that we focus on in early intervention. It is considered one of these naturalistic developmental behavioral interventions. It is very targeted in that we're very much focused on communication and language outcomes. And it's modular, meaning that you can build a comprehensive program for a child around Jasper plus other aspects if you wanted to fill the day. And it's actually what we recommend for kids with autism to personalize those interventions, is to think about who that child is and what kinds of intervention modules or strategies they need. So I'm going to talk today pretty briefly, quickly about intervention targets, core domains of Jasper, and then some research intervention examples. So starting with the intervention targets, Jasper, as in the title, is really focused on engagement, joint engagement with another person, play skills, social communication skills, and then regulation, because of course that's important for learning in general. So why joint attention? So we know from years and years of research, and actually the research that I did back in the 80s was really focused on trying to understand what those early social communication challenges were for children with autism. And so what we know from that research and continuing is that children with autism, and I'll probably go back and forth between children with autism and autistic children, because as the language of autism keeps evolving. But children with autism demonstrate less joint attention than other children. And joint attention is really important to language development. So children will point, they will give an object to someone as if to say, look at this, or I want to share this with you. And that kind of sharing gesture, sharing an experience, sharing some aspect of play, for example, is really important to language development for all kids. All kids will do this, but kids with autism do that less. Why symbolic play? So play in general is difficult for children with autism, and symbolic play is more difficult than functional play. And then social play, playing with another person, is harder than just playing on your own. So we also know that kids with autism may have very restricted interests around play objects or play interests, and they may have very repetitive behaviors with play. And so Jasper will address both of these, both the development of play and also the social aspects of play. Why engagement? So engagement is different from joint attention. It really is the foundation for learning. So staying engaged around a topic, whatever that might be, whether that's communication or whether that's playing with something, is how children learn to communicate or to interact with other people. And then, of course, we need calm and regulated children because they're in a better state of learning. And that's where your behavioral strategies can be very key here. So why do we focus on those particular targets? So we know that in autism, that language, meaning speaking in phrases, by the time the child is 5 or 6, in other words, entering kindergarten, those children have the best social outcomes long-term. We also know that those joint attention skills, those early gestures, predict to language for all kids, but especially for kids with autism. And then play skills, we know to be associated with cognitive skills, problem solving. So again, all of these targets are important to development. And then a second reason we focus on those core domains or core targets is just because of how difficult interactions can be for families or parents interacting with their child with autism. So I'm going to show you a couple of brief videos of little guys. This first one is a child who was just turning 3. He'd already had a year of early intervention, mostly ABA-based intervention. When I say ABA, we're talking in general a very traditional in-home discrete trial approach is what this little guy had. But he still wasn't talking. He had 0 words at age 3. And his mother was mostly concerned that she just couldn't play with him. And so we have just a first session with a therapist trying to play with him in Jasper. Right. So you can see that he's just not happy with playing. He felt like he was done with that toy. He put all the pieces where they belonged. And when the therapist tried to expand that play to try to keep the engagement going, he wasn't having it. And so that was an issue for him. Also, play can just be not, not happening because it's very difficult for the parent to engage the child in the activity. So here's a dad with a 2.5-year-old child with autism, and he's just trying to get him to engage in this toy. Oops. Let's see.
Austin's turn. Question.
Right, so you can see the little guy's interested, but dad doesn't have strategies yet on how to help the little guy get engaged with toys. And so the little boy is what we would code as being an onlooker. He's just watching. Okay, so how do you intervene when you have this kind of interaction? So we started this work back in the late 90s, and it was our initial test of trying to teach joint attention skills in children. We knew that if we could increase the child's gesture use, if they weren't speaking very much, that would translate to better spoken language. And that was the focus back then. So we did a study of about 58 preschoolers. They were all attending the same outpatient early intervention program. It's ABA-based, mostly discrete trial training, 30 hours per week. And these were kids who were ages on average about 4. So they were 3 and 4-year-olds that were getting into this program. And it was oftentimes the very first intervention that they had back then. We randomized the kids to just receive 30 minutes daily of joint attention intervention or a play intervention or just the regular discrete trial training program. And at that time, this outpatient program lasted about six weeks, about 30 sessions that we did, but they were, again, getting 30 hours of ABA. And it was therapist mediated. Parents dropped the kids off at this little school program, and then they picked them up at the end of the day. So we didn't involve parents in this initial trial. And what we found was that if you teach joint attention skills, and here we're really interested in child's spontaneous initiations of joint attention, not responding to prompts, although that's a strategy that we would use in teaching, but we only counted initiations. Well, we found that there was growth in initiations of joint attention. So time 1 to time 2 is at 6 weeks, 30 sessions. Time 3 is 6 months later, and time 4 is another 6 months, so a year altogether. And here we have both the joint attention and the symbolic play group of kids making gains in initiations of joint attention. We found a similar thing with teaching play skills. So if we taught play skills, we saw children level of play, so increasing the complexity of their play was greater for the kids who got the play intervention, but also the joint attention group also increased in their play. But what's notable here is that the kids who were in the program receiving the one-on-one, ABA for 30 hours did not increase in their play or joint attention skills as much, stayed pretty flat. But the big question for us was, would it predict to language? Because our thinking was that if we taught joint attention, that would increase language. We didn't expect play skills to increase language. But what we found was both of those groups, those experimental groups, increased over kids just getting the regular program of ABA. So it was about 15 to 17 months language gain for the experimental groups compared to the just program group, which was about 7 months gain. But also interesting is that, kids are very variable coming into this program. So some kids had no words and some kids had some words. And if you had no words in the beginning or fewer than 5 words that you used and you were 3 and 4 years of age, those kids made the most gain in language if they were randomized to the joint attention subgroup. All right, so that fit with our hypotheses. But this is what resulted in us blending the joint attention and the symbolic play groups together into what we call now Jasper. So let's look at the core domains of Jasper. Again, we have these 4 areas: engagement, play, regulation, and social communication. So talking about engagement first, how do we think about that? And this is different from some of the other NDBIs these are those naturalistic developmental behavioral interventions. We all vary a little bit on what we target and how we go about working on these skills. So in Jasper, a really important skill is this joint engagement aspect. So we're trying to increase children's initiations and maintenance of that jointly engaged state with another person. And again, we're still focused on initiations. But we know that children, neurotypical children, all children, go through a series of states, both developmentally and even within session. So these kinds of engagement states of being unengaged or on-looking, like our little guy was on-looking, to being very person engaged, is a very developmental process. So babies under 6 months will be either they'll unengage and they become more and more person engaged. So they're very engaged with the parent's face. And as they begin to get more mobile, they sit up, they discover objects. They can, in the beginning, become very object engaged. It's very difficult to shift attention between objects and people, but that development of shifting between objects and people increases over the first year of development. And the work of Lauren Adamson, which is what we adhere to, which is in mostly in typical development, is that children learn to speak. They learn language skills, mostly in this supported joint engagement state. The parent is helping the child to engage with objects and with themselves. And that, of course, the goal is that the child can coordinate that engagement. They can shift attention, they can drive the interaction, so that coordinated joint engagement. But those two areas, supported joint and coordinated joint, are real goals of Jasper. And so I have examples of all of these different engagement states. And when we go through the training with you, if you got trained in Jasper, we would spend a lot of time on this, but we're not going to spend time today in this hour talk. But I'll show you one video of a child with in supported joint and what we mean by that. So this is a little guy who's 8 years old. He's minimally verbal. He'd had a lot of intervention, but he wasn't using words at all. And we actually are using an augmentative device or approach with him as well. But you will see that he is in supported joint because he is, while he's not driving the interaction, he's not looking at the person and vocalizing and speaking and being very obvious about his communication. You can tell he's with the therapist. He is responding to her, taking turns, and it's clear that they are interacting together.
I want more doll. Doll. Sleep. Go sleep. Sleep.
So he vocalizes a little bit, but you can tell that he's taking turns and that he's involved in that interaction. And so that's a goal. So I'm going to show you a little video of a little, I think she's 15 months. This is a baby at risk for autism and interacting with a therapist. And she goes through a couple of different engagement states. So if you watch this, then I'll tell you, you can try to guess what those engagement states are.
Let's make ice cream. Oh, blah. That. Yeah, we have a lot of toys. Fun. Fun. Ice cream. Here, sit in here. Fun. Chocolate. fun. Here's more. Ice cream. More. Wait. More.
Okay, so a couple of different states happened there, and you can guess. So in the beginning, she was very object engaged and turned away and just really focused on the objects. And the therapist brings her back into a supported joint engaged role. And you could see that she was looking at her or taking turns, but still very supported. Okay. Moving along to play, another core domain. Our goal here is to increase frequency, diversity, and complexity of spontaneous play. So it's not to increase the frequency of the same act over and over again, but actually diversity of those acts within a level of play. So we do want the child to be spontaneous in their play acts. I mean, play needs to emanate from the child. So we can support and we can suggest, but we're really trying to focus in on what the child can do themselves and what they're thinking about. So diversity is probably the most important variable that we look at in research. And that is the fact that they're pretty flexible within a level of play. And I'll talk about play next. But just to give you an example, this is a little girl who's doing different levels, different actions, but all within the same play level.
Snip, snip, snip.
Here.
Snip, snip, snip.
Where?
I see the beautiful hair.
I see the beautiful hair. The blow dry.
Oh, here's your blow dryer.
Does it make it really sound?
No, no sound.
Okay, so all of those different acts that she did were within one play level, which is child as agent, which was a pre-symbolic area. But we want to see that flexibility. We don't want to see just one act. So that would be a goal. And then the second thing is how children can move up in levels. So in this video, I'm not going to show you, but she goes between sort of more functional play levels and pre-symbolic, and then even some symbolic levels. And you will see that movement within a session, and then we have target goals for where the child's steps would be next in the developmental process. And so play is really well defined developmentally across cultures, across kids. And so children move from what we've combined here, which is simple play to combination play to pre-symbolic play to symbolic play. Most of our kids are coming in at young ages in preschool at simple play and combination play. So simple play just involves what little infants will do, indiscriminate acts, which we don't teach because they're indiscriminate. We start with discriminate acts. But we're going to do an assessment to try to figure out where kids are developmentally, and we can move them up fairly quickly, but at their own sort of pace along this schedule. So the discriminate acts, to take aparts. The next kind of combination or category would be combination play, which is presentation, which is puzzles or putting like the coin in the pig. There's a specific place for things to go. Most of our kids, I would say, come in around this level, or they're doing general combinations where they're just stacking things up in just any kind of order. And I'm going to move along. Pre-symbolic. So a lot of people want to call this symbolic, but it's really where play takes on a pretend quality, but it's not yet symbolic. So pretend self, you pretend to feed yourself. You might put things together to represent something. So you take the tiles, the magnet tiles or the blocks, and you build a house. right? And you have to know that that's what the child is doing, that they're trying to create something. And then child as agent is where the child actually extends an action to a figure or to, that's familiar. So they might feed the doll or wipe the doll's nose, things like that. And then conventional combination is putting objects together that are based on customs or experience, setting up the plates and the saucers and, setting the table. And then a single scheme sequence is where you might feed one doll and then you feed the next doll and the next doll. So it's extending one action to multiple figures. We don't get to symbolic play until the child begins to substitute an object, pretending one object is something else. So they might take a tile and put it on their head as if it's a hat. They might do a substitution without object, pretending something is there when it's not there. Like in this little video, the little girl lets go a pretend balloon and says it's a balloon. And they pretend that the balloon is flying. So the object isn't there. Or they pretend that the doll has life. So the doll, instead of the child feeding the doll is feeding the little dog or something. All right. So doll has life. And then a multi-scheme sequence is where the doll might perform multiple actions. And it can continue on into sociodramatic play where the child may enact a familial role, as if they're sweeping the floor that they've seen mom do, or they talk on the telephone about a conversation, as this little girl does about the teacher. Or they could be enacting a fantasy role. So here it's pretending, there's a superhero or something that's, imaginary. So children over the preschool years will go through this sequence of development. And our kids with autism pretty much fall into that sequence as well, although they may be delayed. So when we think about intervening on play, we think about where the child is in terms of a mastered play level. Where do they play? What level of play are they doing the most? And we do an assessment to determine this. So we try to choose toys then that are at that child's mastered play level in Jasper. And the reason we do that is we want to take off the cognitive load of pushing the play level when we're really working on communication. But in a session, we're going to include toys. Our toy choice and our environment is really important. We want a play level above what our target level is. So if the child has a mastered play level, we're going to have a level above that we're going to also target. And we're going to have a level below to help regulate the child if it gets too difficult. So for example, you might have a child's mastered play level at general combinations. They're just putting blocks together, stacking them in any way. And so our target level might be to bring in figures, which would be more pre-symbolic. But that's maybe going to be hard. And so we're going to also have a step below, which might be presentation combination, which is just putting toys in to a designated spot. That's easier, like a puzzle or a shape sorter in this case. So in our environment, we're going to have toys above, below, but mostly at the mastered play level. And this is going to help us create play routines. And play routines turn out to be really important for keeping that engagement that is also important in Jasper. So we're going to start with a base routine, something that is mastered and easy for the child to do, but still interesting. And then we're going to expand both horizontally and vertically. Horizontally along the same play level, but different acts. Or we could be expanding to the next level up. So those expansions are both horizontal and vertical. And we can do this in our play routine, but if it gets to a point where the child is getting disinterested or the child is getting dysregulated, we're going to then restart. And we're going to go back to our base routine and start over, but always shifting and varying our actions. And of course, we're always expecting the child to be the initiator here, and we're the player. But of course, that depends on who the child is sitting in front of you. So to give you a little example, this is a 3-year-old boy who doesn't have any words according to the preschool. We don't know him, so we did an assessment with him, which we do for all of our Jasper cases. And he basically refused to participate. Let's see if we can see what he does. I should have said that we're teaching assistants, so paraprofessionals, how to do Jasper and the assessments. And so that is one of my team sort of supporting a TA with this little guy. So reported to have no words. He was reported to have challenging behaviors. He actually in the assessment took all the toys off the table at one point. So the therapist is going to model now his first Jasper session. And you'll see in subtitles some of the strategies that she's using to engage him. So his mastered play level that they started with was a combination level. So combination, conventional, just combination play.
Fly, what? Fox. Stack block. Thank you. Stack blue block. Look. Block. Stack block. Block. In the red block. Little black. Black. Where block? Oh. Oh no, it crashed. Power. On top. Build tower. Build big tower. Climb down.
Okay, so that session was actually about 45 minutes long and we kind of spliced it to shorten it up. But so he's using language. I mean, he actually had language, but the therapist is able to get that out in this context. So lots of different strategies, of course, trying to increase diversity and flexibility, et cetera, et cetera. Okay, social communication, another core domain. We focus on requesting, which is to communicate a want or need and direct the behavior of others. This is really focused on in so many interventions, and it's much easier to teach, of course, than joint attention, but it's still important. So we teach requesting. So particular gestures, we're going to model, prompt, and use a series of strategies within the context of these play routines. Reach to request, point to request, give to request are important requesting skills. Joint attention is to share or maintain a social interaction. The gestures we're concerned about there are pointing, giving, showing, and coordinated joint look, similar to requesting, but the function is different. So coordinated looks, we can set up situations to gain those kinds of skills. Show to share, point to share, and give to share. And I think most of you probably know what joint attention skills look like, but we very much differentiate those, and we very much are focused on the child's initiation of those skills. And please note that joint attention isn't the same as requesting, and definitely joint attention is more difficult to teach. And then we always teach joint attention in the context of a play routine. We could model the skill, we can set up opportunities, and we can respond to the child's communication. So this is a little guy who's got some language and is playing, and you can see how the therapist is pretty emphatic about teaching these skills.
Ooh, delicious broccoli. Oh, look, I have a coffee maker. And there's some donkey bread. Ooh, yummy bread. What else do we have? Ooh. Some sauce. Oh, and I have some corn. Yeah, and some tomato and some turkey. Ooh, and here's some more broccoli. Oh, and some cheeses. Uh-huh. There's some bagel. Yum. And there's some beef. Ooh, yummy. I like those. There's some tomato. And here's my pepper. And there's some salad. Oh, show it to me. Oh, I see it. Delicious. Cool. Oh my goodness. Here's a really hot pepper. That's spicy. It's super spicy.
Okay, so the therapist models, she does prompt, but she takes her opportunities and she's pacing those to keep him engaged. And you can see that she's trying to get him to do more of those gestures. Okay, regulation, the last core domain, which is the process of being able to appropriately monitor, evaluate, modify your emotions, your responses, and your behaviors in a given context. Now, clearly, little kids are developmentally learning this process over time, and adults, parents generally will co-construct that or co-regulate the child until the child can be more independent. And that's our same goal in Jasper as well. And it is hard work. So signs of dysregulation could be throwing and banging, moving away from the adult in the room, crying, sometimes vocal repetition, inappropriate affect to the situation, being overexcited. Those kinds of behaviors are signs of dysregulation within session. And so we're going to respond by thinking first about our developmental strategies. What's the appropriate play level? Is this off? And so the child is becoming dysregulated, too low, too high? What kind of environmental supports do we have in the room? What does this child need? Does the child need to sit in a chair at a table? Does the child need to be on the floor? What is happening in terms of access to communication, et cetera? What are the play routines like? Are they boring? We need to change that. And certainly access to communication. So we're going to use augmentative devices with even very young children if that's indicated. And then we're going to use behavioral strategies to address very specific behavior challenges if need be. And so we're going to try to understand the behavior using the ABCs, which people do in an ABA kind of model. So we're going to think about what happened before and what happened after based on whatever the behavior is that we're concerned about. And we're going to think about the function of that behavior. Is it for social attention? Or is the child trying to avoid or escape the interaction? Do they want access to something in particular? Or is it one of those more automatic or sensory reasons? And that's going to drive how we're going to respond. We're also going to make sure that we've got supports for that child to communicate. So we're going to use a speech generating device, an iPad or a tablet. We use Proloquo or Sounding Board or some other software. We're not, that doesn't matter. It's really by choice to help the child to communicate. And we're going to use whatever the child is currently using if they're using it successfully. We don't teach PECs, but if they come in using PECs, then we would continue to do that. Or assigning. And we definitely use visual schedules. We use visual information. We try to set very clear expectations, first then, and a session schedule, especially for older children who want to know what to expect in this context. And then I'm going to show you briefly the little boy that we saw earlier, that we saw him one day and he was crying and didn't like playing. And so this is literally day 2. We changed some things. First of all, the environment, our toy choice. So we didn't want a toy that completed because that was too close to what he was used to. I complete this task and I move on to something else. And we brought in an iPad because he had no words.
People on land.
Right. So you can see that she's just modeling on the iPad. He's already using 2 buttons. He already has the ability to communicate, but he just needed the means to do that. Now mother's goal was for him to use spoken language. He was 3. Our goal was for him to use spoken language if possible. So while we use the iPad, we are still working on spoken language.
Blue block. There's brown. Brown. On. Brown on. On.
Right. So he's making sounds. This is 2 weeks later. He used that iPad, which is smart little cookie. He, could navigate that and used it for about 3 years to repair and to try to talk, but he really couldn't. Today, he's actually older than 7, but he sent me this when he was 7 for Mother's Day.
Dr. Connie, happy Mother's Day. Well, Sebastian, Katie is fun.
Katie is fun. That's his therapist, who I know. And so he now doesn't use the iPad to communicate. He does, use spoken language. So for him, that was just a transition. Okay, so research examples very quickly. So the implementation of Jasper is either therapist mediated, caregiver mediated, teacher mediated in school programs. We're in a lot of schools in Los Angeles, or we do peer-to-peer. So all of those implementations have been developed and we've published on those. And you can certainly read if you want. It's a good go to sleep kind of reading. The findings with Jasper are that they're highly replicable, regardless of the implementer. So we typically will get an increase in joint engagement between the child and their social partner, increase in play skills that are developmentally targeted to that age group. Young kids, toddlers, we can increase in a short period of time functional play, older kids symbolic play, and then increases in joint attention. And again, developmental and what you would expect for the age group. Some examples. So we tend to not just repeat the same study. We have new questions every time we do a study. So we have done studies where we've tried to just give the information to parents and see if that makes a difference versus hands-on coaching. And that's an important question, because if we can just give you information and you can make these changes and, in your child's communication outcomes, great. It's much more cost effective. But what we tend to find is that we have to do hands-on because it's not easy. It's just not easy to teach children who are language delayed or communication delayed these kinds of skills. So in a study of about 112 kids across 5 sites, we compared that information sharing versus hands-on Jasper in home of low resource families. And what we found was that child initiated joint engagement, so they could stay longer engaged socially with the caregiver and they initiated it, increased for the hands-on, that's the top line, hands-on trained group, and the information group didn't really change in those interactions. And so this was just 24 sessions over 12 weeks with a 3-month follow-up. And I tend to do very short-term interventions because the question is, can we make a change quickly? Not can we, stay in there for the long haul, but of course that is something that clinicians will take on over the long haul. So in this study, we also got increases in symbolic play and initiating joint attention. When we work in schools, and we've done a number of parent-mediated interventions with different groups, but schools require particular adaptation because, sometimes children are worked with one-on-one, but other times they're in, and more typically in groups. We like to work in schools because all children go to school, and so we can see children who are more complex and have more diversity. We've done a one-on-one model. We've also done a small group peer model. And in these different studies, again, we find that in this study, which was with toddlers, 115 toddlers, the teaching assistants, so paraprofessionals, had high fidelity to learning Jasper. That's the top line here. And the children were in greater child-initiated joint engagement as well in the Jasper group versus a waitlist control. So in these studies, everybody gets the intervention eventually, but we do a waitlist control. So some are waiting to get the intervention. In another study, 12 classrooms where they used an ABA focus, they used VB-MAP to drive the intervention and the outcomes. But we taught teachers how to do Jasper strategies in one of their rotations. And what we found was that, again, there were increases for the children who got Jasper over kids who were waiting to get Jasper, and that it maintained over follow-up. So the black bars are the Jasper groups and the gray ones are the kids waiting in the same classrooms, same type of classrooms. We also got greater child-initiated joint engagement and initiating of joint engagement of the kids who got Jasper over the wait list. So we can do this with teachers and teaching assistants. We can do this in schools. But we also know there's a lot of heterogeneity in response to interventions. Kids just don't respond the same to any intervention. And so we need to think about methodologies that we can personalize, tailor, and target interventions. And this is the kind of work that I mostly do now. It's really addressing for whom the intervention works and why it works. So we try to think about adaptations that are based on the child's response. And a definition of this kind of model, which is an adaptive intervention model, is a sequence of decision rules that specify whether, how, when, and what kind of measure you're going to use to think about altering something about the intervention, duration, frequency, or amount, and when you're going to do that. Okay, so this is what people do in clinical practice, but in research, we're trying to codify it so that we can replicate what a good clinician does in clinical practice. And the kind of design we'll use is called a sequential multiple assignment randomized trial. Those are my research partners, Susan Murphy and Daniel Amaral, who are the statisticians that I work with and have learned from. And so I'll talk a little bit briefly about minimally verbal kids because they're often excluded from intervention studies. Most people will work with kids who already can talk or we know who are going to talk in preschool. But there are kids that even after a lot of intervention are still not talking in phrases by the time they enter kindergarten. And what we did a workshop 10 years ago, we just recently repeated this workshop. But it's what we know is that it's clear most kids with autism are not nonverbal, meaning they don't have any words. We often will define kids by the number of functional words they can use. So, for example, some kids can speak at school or speak at home, but they don't speak in both contexts. And we often don't know what to do when children aren't speaking by the time they enter kindergarten. The treatment solution is often to just give them more of the same thing that we've been doing, like they need more intensity. Or we do less and we blame the child for not making progress because they're not talking, they can't get speech therapy, right? So that's not a very good solution, either of those. So we did a study a number of years ago with about 60 kids, 5 to 8 years of age. They were minimally verbal. They had fewer than 20 words. In fact, the average was 5 words that kids would use ever. They'd already had 2 years of intensive early intervention. And what we gave all of the kids, because most of them had had intervention in a traditional ABA model, we gave them Jasper, plus we blended Jasper with a spoken language intervention called enhanced milieu teaching, which is really a very structured way to thinking about the language targets and the prompting of language. Half of the kids received a speech generating device. So we put Proloquo on an iPad and supported the intervention with that augmentative device. So here the question is, will that help kids learn to speak faster than if we just did Jasper EMT without the device? And this kind of design is a little crazy. And my research partners were Ann Kaiser and Becky Landa in this study. So it was across 3 sites. So we gave them all Jasper EMT, we called it JASP, with or without the AAC. And after 3 months, we measured how the kids were responding. And if they were fast responders, we just kept going with whatever intervention we gave them in the beginning. But if they were slow responders, we wanted to do something more. So we augmented it. If they got Jasper only, they could get the AAC after 3 months, or we would give them an extra session a week, intensify. But if we gave them the AAC, we only gave them the option of intensifying. So we didn't take away the device. So what did we find? Well, we found that if kids got the device right from the beginning, they made faster progress in spoken language. So here, this graph, the black line on top are kids who got the AAC device, and the red dotted line are kids who just got Jasper EMT. Now, the Jasper EMT kids are making slow and steady progress over the course of this intervention, which was 3 months, measure response. And we also brought parents in the second half, 3 months. So 12 to 24 months, they got some of the kids got a change in their intervention. And then at 24 weeks to 36 weeks, that was the follow-up. So we weren't intervening anymore. So what you see here is that in the black line, the kids made really fast progress on spoken language. We called it socially communicative utterances, so socially relevant utterances. It decreased a little bit at the follow-up, but in part that was because some kids didn't go home with a device for various reasons, but it's still higher than baseline. The other thing we found was that kids with the augmentative device also spoke more novel words and more commenting language, so joint attention language. Okay, so I am now going to summarize. That was very quick, I know. But I think the bottom line of that last study is that augmentative devices do not inhibit kids from talking. It can actually increase their ability to use spoken language. And if they're not going to be able to use spoken language, it increases their ability to communicate, and that's important. So it's access to communication. So to summarize very quickly, Jasper really targets these core challenges in autism, those early developmental differences that we know are important for supporting language and cognition. It's very developmentally appropriate. So it'll do an assessment. We're going to know where the child is developmentally, and we're going to start there with young children because we have the opportunity to fill in those developmental gaps. We're going to tailor our supports depending on who that child is sitting in front of us. So for some kids, we're going to bring in the regulation strategies very early on because we need to. For other children, you know, they're fairly well regulated. And so we'll not have to spend as much focus on the behavioral strategies. We're going to facilitate children's initiations. So the goal here is that the child becomes an independent, spontaneous communicator. And when we look at our outcomes of our studies, those are the ones that we're focusing on. We don't include responding unless we specifically label it as such. All of our outcomes are research backed. And I think what we know about what we've learned over the last 20 years is that our future is to really think about personalizing interventions. We know that a single intervention isn't effective for all kids. What works now might not work later. What works later might not work now. And so we have to think about the combination and the sequencing of interventions over the life course of this individual. So I'm going to stop there so that we have time for questions.
Thank you, Dr. Kasari. That was a fascinating presentation. We really appreciate it. And it fits so nicely with our kickoff presentation this morning on using a collaborative approach to assistive and augmentative communications in children with autism. So really dovetailed nicely. We do have a couple of questions that came in through the Q&A. The first is regarding the study program. Were they children who only had private insurance, or did they have Medicaid? And what socioeconomic variables were involved? Also, was this implemented only in an urban area versus a rural one?
Yeah. Should I stop sharing?
Can, if you want. Yes, absolutely.
Okay. I feel like we're all like little boxes.
Yes.
Okay. So I'm not sure which study program you're talking about. So I've had a zillion different studies at this point. If you're talking about the very first one, kids came in on insurance, definitely. And it wasn't my program. It was just an ABA-based program. That's an outpatient program. So those were insurance-based kids. Most of our work, so we don't charge in research studies. We don't charge people to do intervention. And we try to position it into community so that we are accessing a diverse population. We need to diversify our sample populations in autism because, I mean, we don't need to have just upper middle class folks who can access services in a clinic. That doesn't tell us very much about, I mean, doesn't represent autism, and so our evidence base is limited. So most of our kids, I imagine, I don't know if they have insurance or not, because we don't ask them to pay and we're in schools. But a lot of our kids are very low income. So in Los Angeles, I do a lot of work in Los Angeles Unified School District. And just to give you demographics, 80% of the kids who go to that school district are free and reduced lunch eligible. 75% are Latinx, Latini, whatever the term is that you're comfortable with. About 40% are Spanish speaking families. So we have a pretty, I wouldn't say it's so diverse. I think it's a pretty low income, primarily ethnic minority sample. And there are 15,000 kids with autism in LAUSD. So there are no shortage of children. And then was this only implemented in an urban area? Yeah, a lot of my studies are urban, but I do multi-site. So some of them are rural. You know, some people go into rural homes, and we've been in different countries teaching people. And I think, you know, you have to think about the cultural tailoring of any intervention. While I say that these are developmental targets and they kind of cut across, you know, globally and economic and everything, you know, ethnic, racial diversity, there's still a need to target and tailor to a family and what they're capable of doing, or how a school operates or a daycare center. So there's always some tailoring.
Thank you for that. And yes, it was the very first study this person was referring to. And that sounds similar to many of our TAP network sites, since we are across the state of Illinois. Some are located in urban areas, and others are in very rural areas. And there's a big mix of socioeconomic factors across the people that we serve as well. So good to hear. The other question, these two are very similar. Do children of a higher age range benefit from Jasper? And what is the oldest age of children who have been successful with Jasper?
Yeah. So yes, a higher age range. Higher developmental age range. Yes. So kids can be talking, certainly, and we can work on things like flexibility and peer engagement. And so, yes, we do that. And I think Jasper's really great for that. It's really great for flexibility, because you'll notice, well, it was fast, but just the way in which the therapists are working to be flexible. So example, stacking those blocks with that 3-year-old boy, she never stacked them in the same way. She didn't put all the reds together, all the blues together. We're kind of mixing it up and trying to work on flexibility right from the beginning, because our goal is not to narrow the child's interests. That may be his interests, but it's to really expand his horizons. So following a child's interest, we do, but only to a certain extent, because the goal is, can they go to school? Can they play with their peers? You know, that's really the goal. So higher age range. So we've had studies up to age 11, actually, that are minimally verbal. Now, clearly, you're not playing with baby toys and you're trying to be functional, but we do have kids who, you know, just still are not talking. And so we try to work on that flexibility, giving them access to communication with an augmentative system. But I think that it would be a module. So I never think about Jasper for 20 hours a week, right? So we would insert it into as a strategy, maybe across the day for a family, or in a school program for a rotation, you know, like a center-based rotation, something like that. because kids need so many other things. They need executive function modules. They need to learn to read and to write. And our minimally verbal kids, what was interesting about that first study I told you about, the kids had a receptive language age of minimum 24 months for that study. So they were already, understanding certain things, but of course they were 5 to 8. So even if you have a receptive language age of 24 months, you're pretty delayed, and they weren't really speaking. But about a third of the kids that we saw could read. Now, how could they read? They were in school. Their teachers are teaching literacy, exposing them, their families are exposing them to books and literacy. And I think that it's so interesting to think about kids who go from literacy to language. So they use reading and words to bridge into using spoken language or an augmentative device to communicate. I think that we need more research on that. We need to explore these options for kids.
Good, thank you. Someone an attendee in the chat wants to thank you so much for all your years of ongoing research and as a longtime speech language pathologist. She appreciates your dedication to emphasis on the whole child and what is best to emphasize flexibility and expanding the child's overall functioning.
Yeah, it's not easy though.
No.
It's really not easy. And definitely interventions vary on how much they focus on doing things that look neurotypical and letting kids play. So I had a question actually from an adult with autism who asked me about appropriate play. So what is play? I mean, if you watch kids play, what is appropriate? I mean, they do all kinds of things. I mean, maybe they can't do certain things in school with play objects. So some people would say that taking a block and making it into a gun is inappropriate, right? They are not allowed to do that. Or they do other things with toys, but mostly play is whatever emanates from the child. And you want to think about that in developing those play routines. So people always want to have like a play set, like a barn set. And so teach the child how to do these things with the animals and the truck and so on. We have none of that. We've seen all kinds of things with blending different kinds of toy sets and the things that kids come up with. And that's the fun part of intervening, especially with something like Jasper, which is very fluid and creative and still has pretty set strategies for getting you to where you need to go. If that makes sense.
It does. Thank you. We have several more questions coming in, so this is wonderful. Have you found that some of the children you were working with were hyperlexic?
Yeah, that happens too. Mm-hmm. And I don't specialize in that, but I think that's just so interesting. How do you use that? How do you use that interest in words and decoding and all of that to your advantage to teach them, language, or I think also of kind of broadening their perspective. How do you get them to sort of see the world their perspective is great, but also from another person's perspective.
So I want to dovetail off that question real quick. When that happens, how do you change your Jasper strategies due to the hyperlexia?
Well, so they'd be hyperlexic if we had a lot of books or words or those kind of things. But usually with play, you're not seeing, words that they're, reading in the play itself. Now, I'm thinking with little kids, they come in, focus on ABCs and colors and things like that. I don't have a problem with that if we can expand, if we can get the child to be flexible. So we think about those really restricted interests or special interests or whatever. If they're really focused on it and they just can't shift their attention, don't want to play, don't only want to do that, we might have to remove that for a little while. As in have toys that don't have letters on them. But we're always going to want to bring those back in because we want to see if we can create flexibility. I've had kids who've been obsessed with books and they only want to sit there and like look at the book and so on. And as long as I can have objects and routines and things where I can incorporate the book and we can expand out, it's totally fine. But if we can't, we're probably going to have to remove it for a little while and bring it back in. But that's just a strategy.
Thank you. Allison wants to echo the previous commenter's gratitude for your research. It seems as though Jasper is honoring children's communicative attempts and modality. Can you discuss how you see Jasper aligning with some of the neurodiversity movement's push to accept autistic children?
Yeah, so I have other interventions besides Jasper, so I've tried not to be a one-trick pony. So one of the things that happened with us with Jasper is kids went to school and they didn't play with their peers. And we were thinking, oh my goodness, we just worked on all this play, but it sort of fell apart. So we have another intervention that was actually named by a neurodiverse adult called Remaking Recess, freely available. If you look at our website, you can just download it. Got some, we've done some trials with it and it's got evidence. And it's really changing the environment. It's thinking about how you change the environment so that kids can engage. Because what kids tell us is that they want to have friends and they don't know how to play and they feel sad. And this is in like elementary school. And neurodiverse adults have told us the same thing. So there's some adults who are saying, neurodiverse adults who are saying, just accept how the child plays or does or whatever. But that's not what we hear from everybody. And in fact, I think it's really important. And usually when I do my kind of school social intervention thing, talk, I have an adult who talks about her experiences going through school. And then I show two kids who are third graders who are in the midst of going through what she's reflecting back on. And it is different. So what we all as adults think about having grown up and had many more experiences and read more and talked to more people and maybe have formed our identity more, we have a different perspective than how we might feel in the moment going through something. And I think it's important to remember that developmental piece. So when little kids are wanting to play with other kids and are getting rejected all the time, our goal should be to help them, both peers and our child with autism, to find a way to interact and communicate. And so that's kind of what Remaking Recess does. It really focuses in on the adults and the materials on the yard at school so that we're really changing the environment for the kids so kids can find entry points that are going to be receptive to them. Because you can teach them till you're blue in the face social skills, and if they can't do anything with those social skills if the environment doesn't accept them. So the first thing is to change the environment. Not so much the kid.
I'm seeing clapping emojis. Do you do any consultation with adults and their families about strategies? And if so, are you willing to share your contact information? And then a second question, if you are willing to share your slide presentation, I know you may want to take some of those videos out. We can send them along as well.
I think if we make it a PDF and not the videos, yeah.
Oh yeah, definitely.
Yeah. I think that's okay. I mean, I've probably presented this enough times that probably everybody has these slides. I mean, different little combinations, right? Yeah, the funny thing about videos is that you have to get permission. And then I want to ask them when they get to be 18 if they can give permission again, if it's possible, just because you never know, right? Some kids do not want to be identified. They don't want to be part of somebody's presentation, even if they're mothers or even if they said earlier. But consult with adults, meaning autistic adults.
Yes.
Oh, yeah, I have autistic adults in my lab, and actually Remaking Recess, the whole manual is kind of created by my autistic adults. So they're really important members of our lab, and I have grad students with autism. So, we sort of talk to them about what works for them. I actually work with some programs in Los Angeles that work with adults that I just love. I mean, they're really working on the young adults' identity and their skill set, and they're trying to get them into careers, either college or employment or something, but really taking a very different approach. Instead of teaching them employment skills or social skills on the job, which really isn't the issue. It's really more around executive function, planning, managing your anxiety, all of these other things, and then figuring out what it is you want to do. They just do a marvelous job. I think that it's a really great program. So I'm happy that's called Evolve, EVOLVE, into the workforce. It's just a couple of women that are doing really good work.
Great. Thank you so much. So we could share the Kasari Labs.
Oh, sure.
website.
Mhm.
You think
And
would be best?
Remaking Recess it might be on my lab website, but it would be on the AIRB Autism Intervention Research Network for Behavioral Health. We've been doing it through that for a while now. And now we're trying to get sustainability implementation into schools. We teach people in schools, but there's such staff turnover. We're looking at implementation strategy interventions to try to get things to sustain, which is hard. But it's so easy to do these. Some of these Jasper's not easy to do. Full disclosure, it's not easy. Remaking Recess is easy. So those easy ones, we need to disseminate a little bit more broadly.
Yes. And did you say Remaking Recess is available on your lab's site?
It might be on the lab, or it might be on AIRB network.
Okay.
Or
We'll find it.
yeah, I think if you just Google Remaking Recess,
Yep.
You should be able to find it. But yeah, the manual you can download. It's open access.
Oh, great. We'll send that along with the slide decks after.
Yeah.
Good. What a great discussion. Are there any other questions?
I went fast because I figured you guys would have tons of questions. How is this different than something else? And the usual questions I get.
Right.
But that's fine.
Quiet today. We had many that were answered. Oh, good. And people are giving lots of applause, and they really appreciated your presentation today. Excellent.
Who am I talking to? Is it speech and language, OTs, parents?
There's a mix across the board. Yes. So we open up the registration to all individuals in Illinois due to our grant. And so for those there are some licensed clinical social workers, some clinical psychologists there are speech language paths, some educators, parents, other types of clinicians, and some are requesting CEUs and others are not. So yeah, it's a very broad mix of people, and many that are professionals are also professionals and parents. So as you might.
Yeah. Well, autism is very diverse, and we have so many interesting issues these days, just the language of autism, not even just the language of the kids, but the language that we use. And I feel like I'm always kind of policing myself. So, but there's a lot of different stakeholders in this game, and people have very strong opinions, and it's interesting. I don't think that we're doing anything to make kids look like the next kid. Oh my goodness. Who would ever want a child to not have their own personality, right? We're trying to uncover that personality in the ways the best ways that we know how to at this point. So a lot of work needs to be done though.
Does. That made me think of another question. When you encounter a child, you want them to express themselves, but let's say in your the play-based portions, you're noticing a child that is really playing in such a way that's kind of throwing up a red flag. You know, maybe they've got a plastic knife in one hand and a Barbie and they're sawing it or something. Like, how do you, that's a terrible idea, but some children may exhibit some behaviors that give you pause. So then how do you shift and flexibly move, through that play segment while still honoring them, but also kind of teaching what is appropriate play if you can?
Well, we would redirect that probably. So that's a difference with Jasper's. We don't imitate everything the child does. Imitating a child's actions is a good teaching strategy for sort of facilitating that engagement. But if a child was doing even like, I don't know, waving something, a rag or something around the room, we're not going to follow them, get a rag and do that. Because it's non-functional. And that may be their thing, but that's not what we need to do together. So if you're sawing off the doll's head, I would probably just redirect that to having him do, I'd probably just model with a knife on a piece of fruit. They love those fruits that Velcro and that come apart. We have tons of those. And so I would just redirect it, and I probably wouldn't make a big deal about it. And if it was a kid in school, and I saw that more than once or twice, I might say something to the teacher and say, is this a concern of yours or is something going on? But otherwise, I would probably, kids do stuff like that. What do you see on TV? You do all kinds of things. So I don't know if it's a red flag or not, unless I see something more consistent or the school is telling me something.
Got it. Thank you. Withhold judgment. Get more data.
Yeah, withhold judgment. You would not believe the things we see. And we had, I could tell you lots of stories. We just have these kids. We just love these kids. We had a little boy. I usually show videos of him. He loved the 7-Eleven big gulps, but you're not supposed to have that in school. He was like 3. You're not supposed to have that. And he was a minimally verbal kid who learned actually to talk. He did great, but he would come with, a big gulp in his backpack and then sneak it out, so there's all those kind of things. And so what do you do about that? We probably just not have him drink Coke in the session, he could wait for that. But, kids they have lots of different things that they do, and who are we to judge,
Good point.
Yeah.
We did have another question come in. Are there parallels to Greenspan's floor time therapy with Jasper?
Well, I think there are parallels with all therapies, including DTT with Jasper. We all have kind of similar strategies. And if we're paying attention to development, we might have some overlapping ideas, but we're pretty different. Jasper's pretty different from floor time. And I know that for a fact because one of the other organizers of Greenspan, Serena Weeder, collaborated with us on an early project with toddlers in New York. And she wanted us to come because she thought that what I did was floor time, but I had the research backing. But she quickly found out that what we do is very different. So for example, we would not focus on the face-to-face all the time, the emotions. Like she wanted to know, like if a child was playing with a doll and going to the top of the house and the doll fell down, and we would just continue playing with that. We might say, ouch, or I don't know, something, give it a word, and keep playing. And she wanted us to stop and talk about the emotions. Like we would never do that because that interrupts the engagement. So see, for us, the most important part is the play engagement and to kind of pretending like you're the playmate of the child as opposed to the therapist of the child, if that makes sense. So there are real differences. There's differences in evidence. There's differences in the targets. we focus in on language or communication outcomes. So I would say that we're pretty far, well, depending on your lens, pretty far from floor time, pretty far from DTT, pretty far from everything. And yet, if you think about them all together, they're all pretty close.
Thank you for that. Dr. Kasari, it has been such a pleasure to have you share your knowledge, expertise, and the results of your research studies with us in this presentation today. I know folks are going to go back and utilize that. Maybe many will get interested in getting certified in the Jasper approach. And we just couldn't be more happy to have you and so grateful for your presentation today. Thank you so much.